buckle up, enjoy the ride with Crystal Petry. Consulting, so inspiring, pushing you to your dreams. You can begin.
Hello, and welcome to another episode of 60 Minutes With. I'm your host, Crystal Petry. Today, joining us on the podcast to educate me and you about dementia, we have Dr. Karen Whisenhunt Saar. Yay, I got that.
You did, thank you.
I got that. So if you possibly have a family member or a friend or a coworker or just someone you know that's dealing with this disease, this is the podcast for you. So welcome to the show, Dr. Saar. How are you?
Thank you for having me. I'm great.
Good. So you are going to talk to us about dementia, but you are a speech language pathologist.
Yes.
So first, explain to everyone, including myself, exactly what is that?
Absolutely. So a speech language pathologist, for dementia, we're one part of a big team, right?
Okay.
We play one role. In general, a speech language pathologist supports communication and swallowing across the lifespan, from birth to from birth to death, essentially. There is a role for us. We have different skills across our scope of practice that support both developmental, so you're born with it, or acquired, something happens to you and creates this disorders in speech, language, social communication, voice, as well as swallowing disorders. That also falls in our scope of practice.
Okay. A lot of your research and your time is spent directly working with dementia patients and studying that. How does a speech language pathologist help with dementia?
That's a great question. It's actually one that I hear a lot. And I hear it a lot from my students, right, who are studying to be speech language pathologists. They also wonder, like, why do we have a role here? And I guess the easy answer is if we look up our organization that governs speech language pathology, right? Mm-hmm. It's in our scope of practice, cognitive communication disorders. So cognitive issues and communicative issues dealing with neurological problems is part of what we do. But I think that the answer is actually a little bit bigger than that. If we think about, I had a student just the other day, I think she answered this beautifully. She said, well, speech language pathologists, they help people communicate,
right?
And people with dementia need to communicate, right? And I think I've never said it that well as my student said it in class the other day. And so we play a big role on not only supporting the person who is living with a dementia-producing disease, have access to strategies and resources to interact with others, but we help train other people to support them to use communication strategies. We can train family members, other healthcare workers, as well as put environmental modifications in place like signage, things we can do in the home and in facilities to make navigating the world and interacting with the world and other people a little bit easier. But I do think as a discipline, there are a lot of people doing really good work, but by and large, I don't think we advocate for our role enough. And we're the member of that team. We're not the neurologist that diagnoses it. There are a lot of very important things that happen for this population that isn't us. But I do think that considering quality of life, anxiety that comes along with declining cognition and loss of communication abilities, that's really important. And being able to support someone in maintaining social connection and maintaining a higher quality of life and really preserving that dignity of who that person is, that's really important. And when we don't educate people about the fact that we're here and we can help with that need goes unmet.
When you say declining cognitive, what does that mean?
So it differs based on the diagnosis. So dementia isn't one disease. It's actually a collection of symptoms that's associated with a number of different kinds of diseases. For example, Alzheimer's disease is a very well known. It's the most commonly diagnosed dementia. So Alzheimer's disease is created by the presence of certain plaques and proteins in the brain that cause degeneration of the brain tissue. And then the symptoms that come along with that are called the dementia. But there are other diseases and events that can create dementias. And it differs by what the underlying disease is, how that progression will look. In Alzheimer's disease, for example, we see loss of memory, problem-solving abilities, some naming abilities, that kind of thing earlier on. And so those are some kind of classic early symptoms of an Alzheimer's dementia.
So is Alzheimer's and dementia different? Are they the same with just different names?
They're different but related.
Okay.
So for example, Alzheimer's is the disease process. Dementia is those cognitive, communicative symptoms associated with the Alzheimer's disease.
Okay.
So for example, there's another disease called Pick's disease, because there's a different type of protein present in the brain that's creating deterioration, and that's associated with something we call frontotemporal dementia. So it's a different kind of dementia, but we have this set of changes to cognition, communication, personality that are the result of another underlying disease. But we tend to sort of lump them all together as dementia, but there are actually dozens of things that can cause a dementia, and so those are actually separate. Those are the disease processes. There's also something called a vascular dementia, which is the result of a series of small mini strokes in the brain that initially cause damage to certain parts of the brain that deal with memory and language, and then you see kind of a gradual stepwise decline after that. So dementia is actually separate from Alzheimer's, but they go hand in hand because the disease Alzheimer's leads to dementia symptoms.
Okay, so let me make sure I have this correct. Again, I'm learning here. So we have Alzheimer's is kind of the foundation, if you will.
Right.
And if I'm wrong, please correct me. So we have Alzheimer's, which is kind of the foundation.
Right.
And then growing from that, we have dementia and other different kind of cognitive diseases.
Well, so Alzheimer's is one of the diseases.
Oh, okay.
And so Pick's disease would be another one.
Okay. And dementia, that would be another one?
So dementia would fall under all of those. So dementia means this classic set of symptoms. So loss of memory plus loss of problem-solving ability, loss of language ability. So dementia is referring to a collection of cognitive symptoms. And those symptoms are related to a number of different diseases, such as Alzheimer's disease. That the degeneration happening because of the disease, we see those changes in that person, in their memory, in their problem solving, in their language, and we call that dementia. And the dementia is really those symptoms. So multiple diseases can produce those symptoms. Does that?
Yes.
It's really,
okay, I get it.
Okay.
Yes.
And we sort of, I think the reason it's confusing is because even I am guilty of kind of interchangeably talking about these things because they're so closely related that that distinction can get lost in the conversation.
Okay. I think the first time that I heard of Alzheimer's, and I know we're talking about dementia here, the first time I heard of Alzheimer's, and maybe a lot of other people, was when President Ronald Reagan passed from it. And then I feel like it became like a national spotlight, a national thing. Would you agree? Or was it big before then?
I guess it depends on who you speak to. I think that there is a lot of truth to when someone who has a big national presence suffers from something, that it gets more attention. So I do think that event did help draw more attention to the disease itself, the dementia symptoms that result from it, what that decline looks like for a person and their family and their community. So I do think something like that draws a big spotlight on it. The prevalence didn't change, right? People who nobody knew were living with that long before. I think that there is something to be said for that. It's unfortunate that someone has to go through that experience. I know another public figure, Bruce Willis. He's been in the news a lot. I haven't followed his case a lot, but I've noticed that that I encounter people who know more about what's going on with those types of issues because they are a fan of his. So it does help bring attention. That kind of attention can provide information to people. Mm-hmm. And I think that goes also a long way towards battling things like stigma surrounding dementia. That's a big one, unfortunately. A lot of people don't even, they delay seeking care or seeking that diagnosis because they're afraid to be part of that stigmatized group. Mm-hmm. And when the public is more aware and more educated, we can do a better job of supporting people and kind of breaking down those stigmas that really lead people to social isolation. And I imagine, when you're dealing with your life completely changing, being isolated from people who you thought you were your friends because they don't understand what you're going through, that just adds another layer onto the struggle.
And what are some stigmas surrounding dementia?
I talked with one woman, for example, and she was in very early stages. So she wasn't kind of the classic kind of how a movie would portray someone with dementia, right? Mm-hmm. She was still very independent. She actually does a bunch of advocacy work surrounding legislation and dementia. And she told me a story of, after she got her diagnosis, when her friends and neighbors found out, there was a woman who had been her neighbor and she thought her friend for decades. They raised children in the same neighborhood. They would always stop and talk. She was walking down the road and that woman was walking down and crossed the street to avoid her.
What?
Yes, and those stories are not uncommon. And I think that there's two sides of that, right? Her friend probably didn't know what to do because she didn't understand what was going on and just avoided it instead of providing support. But for that woman, just like that, she felt isolated, separate from, now she was no longer a part of the fabric of her community because they knew that she had this diagnostic label.
Mm-hmm. As a speech-language pathologist, did you have to take extra classes or certifications to become proficient with dementia?
That's a really great question because the answer is yes and no. Okay. So our graduate programs in speech-language pathology, it's a 2-year program that provides us with a foundation across the board, but our scope of practice is so big. So every year we're actually required to do 20 additional hours of continuing education to keep our skills up to date and keep them strong. So within that, I did learn when I got my degree a foundation for this. And honestly, I think when I started my job, before I came to Lamar to work here in the clinic and the program, I worked in skilled nursing facilities, so nursing homes, and adult home health. Okay. And I felt like I had a lot of people on my caseloads who had dementia. So I was, assigned to help support memory and communication, but I felt so underprepared for that. Okay. So I did seek out additional training and coursework from experts in that area to help me learn how to be better at that and do a good job. So it's kind of a combination of you get a foundation, but then you do specialize as you go. That experience, right? That's the best teacher. Mm-hmm. But then I did continue and I still continue to seek out opportunities to learn from other experts, speech-language pathologists in cognitive communication.
So why did you decide I want to learn more about this so I can help more? I'm sure, and it's no fault of the person, but I'm sure other people had come through that position and worked with dementia patients and just went on to the next thing. Mm-hmm. They didn't take the extra step of, I'm going to seek out other people in this field, I'm going to take extra classes and continuing education. Why did you decide to do that?
I think it's a combination of factors. I remember as a little girl, like really little, before I could talk probably, my parents would take me on Sundays after church. We would go do communion at the nursing homes, right? So I remember being in that setting and valuing those people in that setting, right? And I don't know, I just kind of think this comes together. Decades pass. I think being there and especially realizing I don't know what to do, I felt I felt challenged by that need to kind of fight against that and say, okay, I've got to figure this out. We have to do better. And I actually think that's part of why, even though when I came to Lamar, I worked a lot with children as well, that's part of why I wanted to come into education. Because I could do a lot as one person, but I thought while I'm figuring this out and I'm figuring out how we can do a better job, I can be impacting, 30 people a year who are going to go out into the community and do that. So I really think it was a combination of having kind of a history, being in settings where we tend to kind of place people who are uncomfortable or in the way of society, right? I know that sounds very harsh, but we institutionalize individuals who we don't have the capacity to care for. That didn't scare me because my parents made sure I grew up around that. And then realizing I needed to be able to do a better job, that what I was doing was insufficient. Now, that didn't mean other people weren't doing a good job, but I wasn't, right? I had to learn to be better. I think that was a combination of the two. And by saying we institutionalize people that we don't have the capacity to care for, I by no means blame people that have to put family members in a place that is equipped to care for them. It's our healthcare situation has created a huge burden on our society. I looked at a recent survey, labor statistics, and it looked at the past 10 years of unpaid labor surrounding dementia care in the United States. So unpaid labor means family members, spouses, adult children, right, who don't get compensation to care for their loved one with dementia. And the number was, in 2022 alone, was something like $340 million of unpaid labor. So that doesn't count the people, the nurses and the faculty or the staff at a nursing home or other inpatient facilities, or someone who's paid to come into the home to help.
Or speech language pathologists.
Right, or speech language pathologists. We don't count in that because we do make money for the work that we do. That unpaid labor is the family members who are probably sacrificing a job, right? They're sacrificing access to income to support their families so they can care for their loved one. And it's a very challenging, and it can be unsafe if you don't have, the right kind of support. So it makes sense to seek out that support. But what doesn't make sense is that we have this economic problem that people have to sacrifice to care for the people that they love and who need that. And those statistics, it could be a spouse who also has health issues that they have to take care of. It could be an adult child who is also caring for kids still, right? Might have kids that haven't grown up and left the house. So managing caring for children, caring for a parent, trying to also balance a job and make an income, it's an impossible burden. And it falls more heavily on women, which that's not to say that men don't also contribute to that unpaid labor, but the statistics show that it's more frequently women, and it's more frequently women from non-majority communities who have to give up that income.
Why do you think more women, and again, we're not man bashing here, but why do you think, there's two questions. Why do you think it's more women that take on, for lack of a better word, that burden of taking care of a family member, a mother or a father or something, and why is it more women from minority communities? But I loved how you phrased that, majority communities. I'm going to start using that.
Thank you. Well, first of all, I'll qualify my response with this has nothing to do with speech language pathology, so it's outside of my scope of practice and purely my opinion. I do think that our society is built on structures that put caregiving and nurturing more into the female realm. I have seen it is a burden, but it's also a beauty, right? There's something beautiful, and I've seen some wonderful husbands who have taken on this role and just seen the beautiful side of humanity and what had witnessed. So I'm not male bashing either. But I do think that we see that with childcare too, right? It's not that men and fathers don't take on that, but there's this expectation that it is the woman who does. And I think that comes from a long history of how our society has been structured. And I think that that is also the same response for why non-majority communities have to, they are socially and structurally disadvantaged from access to a lot of the privileges that other people enjoy. And I think it's a culmination of many, many factors.
How long have you been working with dementia patients, and how long has your continuing education been going?
About 11 or 12 years.
Okay.
So I started out, like I said, in skilled nursing and home health, and then after a few years moved into the university clinic setting, where then the balance became kind of some kids and some adults. And I worked in clinical education doing that, so I worked with students who were learning to become clinicians as well. And then the continuing education has been part of that entire time as well.
When I think about dementia, or I hear that word, I automatically think that, or automatically see an elderly person. But with research, I've discovered that doctors and clinicians are seeing it in younger and younger patients now. So why do you think that's happening in younger and younger patients? And can we still consider that, or can I still consider that an older person's disease?
I think that's, I love this question because there's a couple ways I want to answer it, so I'm going to just do them all.
Okay.
One, I think thinking of it as an older person's disease tends to pull us towards this expectation that older people get dementia.
Yes.
And the problem with that mindset is that when we sort of lump aging and dementia in together, we risk overlooking those red flags that something's wrong neurologically. So if we're just like, well, you know, mom's a lot more forgetful, and there's one thing between kind of slower processing time, being a little slow to forgetting a word here and there, right? That's healthy, normal aging. That's not a problem. But if we're seeing signs that something bigger is happening and we're just, well, she's getting older, right. Well, it's old age, right? Then that lack of understanding what healthy aging looks like makes us miss an opportunity to find out that something's going on and get help early on, right? Alzheimer's disease, for example, the most commonly diagnosed disease related to dementia, typically we see the onset after the age of 70. But we hear a lot about early onset, right? That happens before that. Individuals who have Down syndrome, for example, prevalence of dementia is actually quite common in the 40s and the 50s with that population. So it's not an old person's disease, and thinking that can make us miss really important signs that there is a disease process in someone who is aging. Healthy aging, our vocabulary continues to grow the older we get. Now it might take a little longer to get that word out here and there, or small changes might happen, but people can live to any age and be cognitively healthy. So it's not just something that comes hand in hand with aging.
What are some signs or early signs of dementia?
So it depends on the type.
Okay.
For Alzheimer's disease, you will see loss of memory earlier on, some less complexity in being able to problem solve or plan for things, some naming difficulty, and then those things get progressively worse with time. Mm-hmm. With other dementia, so like the frontotemporal type of dementia, kind of something that differentiates that from an Alzheimer's disease symptomatically would be personality changes happen sooner, which is really hard for families, right, when that's the first symptom.
Mm-hmm. And a lot of times I feel like when the personality and the attitude changes, like your family members, their attitude changes. So, you know, the person with early signs of dementia, you know, they're agitated, they're not as patient, so the reaction is the exact same. This person is agitated, this person, their patience is low because of what you're dealing with, not knowing that it's early onset, which is horrible.
It is. And we tend to mirror each other. I think even when we know, right? When this is someone who we've spent our life with, it's very hard to kind of reframe our thoughts and support that. It's very easy to be like, no, you know how to do this, you know this. And part of that is just we're used to that, and part of that can also be that acceptance of where we're at. And that's a hard journey.
Now my next question, I know that you are not a doctor or a physician, a medical doctor, excuse me.
Yeah, no,
you're not a medical doctor.
Myself.
Why do you think we're starting to see like early onset in the 40s and the 50s compared to, you know, 70s, 80s?
I really can't fully answer that within my role as a speech language pathologist. I'm not sure whether it's a matter of diagnosing something that just was previously unseen, or if there are other factors contributing to that.
Is there a cure for dementia?
So, unfortunately, no, there's not, and that would mean, you know, kind of finding a cure for each contributing disease, and there is currently not. For Alzheimer's disease, for example, there are some medications that help treat those symptoms, that help slow the progression, but they don't reverse the disease or stop the disease process.
Are we seeing dementia in women more or men more, or is it about the same?
So it depends again on the type of dementia, but in the more common kinds of dementia, the numbers tend to be more heavily female.
Okay.
But it is distributed across both genders, but more heavily women. And that can have to do with like how long people, life expectancy, and there's a lot of variables that kind of play into that.
Well, this next question, it'll probably be the same answer. Is there like certain character traits? And I'm asking, you know, for my listeners and for my viewers, is there a certain character trait that lends itself more to getting dementia later on, you know, 40s, 50s, 60s, 70s? Like, okay, this person was a great multitasker and then ended up, you know, getting dementia or something like that. Is there like something specific like that?
So there are certain risk factors, even though, like we said, age isn't dementia, but it's more prevalent after the age of 70. So the longer someone lives, and we're seeing people are living longer and longer, that can be a risk factor. I attended a conference where several neurologists presented studies about how diet can be a predictor, so that the type of diet someone had during their life. Another really interesting study I read by a woman named Ellen Bialystok. She's a researcher in bilingualism, but she did a study looking at individuals who were bilingual and onset of dementia. And it's been a long time since I've read it, so I think I remember the details, but she saw that in the people who participated in her study that she looked at, she saw that the bilingual individuals were later to develop symptoms of dementia, even if they had an underlying Alzheimer's disease. So they, for example, she saw about a 10-year delay in onset of dementia, but then at that point it progressed more rapidly in those individuals. So it kind of took longer to start, but then
once it started.
But I find that really interesting. I don't know why, right? What's happening in the brain of someone who's bilingual, that maybe they have some sort of strategies and compensation abilities, flexibility, that kind of staves off observation of those symptoms until later on. So I don't fully understand all of that, but I do think it's fascinating because it does tell us that maybe there are things that we can do to help delay symptoms, for example.
Right. As a speech language pathologist, what kind of therapy do you use to help patients with dementia?
So there's two different kinds. We call one of them direct and one of them indirect. So direct is just what it sounds like. If you were my client, we would work together and we would work on training certain skills. So it might be training in use of compensatory memory strategies. It could be training in kind of sequencing certain steps a specific way to remember a name or remember kind of something for safety. But what's most common is the indirect, where we work also with the family or with other caregivers on the healthcare team to train them in communication support and strategies to make environmental modifications. So putting signage up to help with orienting to where you are. A really great idea for in the home is creating a memory station with important information of what day it is, important things happening that day, what time it is, so that family members and the person with dementia can regularly orient to that space. So that can reduce some anxiety, but also help provide that person living with dementia this routine ability to look to one place to find information. It's supporting them instead of asking them just to remember things or relying on what's now not a strength. It's helping them kind of overcome that with a strategy. So working with and training other care partners, making changes to the environment for orientation, safety, and memory is part of what we do. So we kind of set that up, we make sure it's working, we make adjustments to help. And that's, I think, one of the most powerful things we do within communication. So I like to encourage individuals to have something to support memory and communication that's visible. So that might be creating a low-tech augmentative device, like a book with pictures about very daily routine activities to help sequence those. Or with pictures of, this is our favorite restaurant, so a picture of some of your favorite things to eat there. So when we go to order, it's not just I'm ordering for you because I know you, but you can point to some of these familiar things. If you can't remember that word, you can point to the enchilada or the hamburger, so that you're empowering someone to be more independent by supporting them with those pictures. Those are also nice opportunities to put good memories of family, hobbies, right? I worked with a woman in the skilled nursing facility, and this was during my first year, so a lot of those memories from your early on are powerful. And when I first started working with her, her dementia was very mild, and in that time we created one of those books. So we had, what was great about that is that she helped, right? She was able to tell me exactly what she would call those things, how she would talk about that, what people, what activities she needed support with. And in the back of that book, we were able to put her favorite scriptures, her favorite hymns. And she was so independent at that time, but fast forward a year or two, she declined rather rapidly, which was really, really hard. And towards the end of her life, when she could no longer speak and really she was too weak to reach out for that book, her family could pick that up and they could sing her favorite hymns, they could read her favorite scriptures, they could talk about the people that mattered to her. So even past the point in time where she was independently benefiting from being able to use that, other people could use that to put a smile on her face. So it really kind of continued to help support that connection.
And that sounds like something you could do at home.
Absolutely.
Like a family member could do that at home.
Yes, you don't need an SLP to do that. Now we might be able to help support some ways to use it for communication, not making it a test, not just saying who's that, what's that, when was that, right? Because that's hard. Just cold recall of things, but making observations. I remember her. That's Aunt so and so, right? And then that person can recognize. So recognition memory, seeing something tangible. We have these objects up here in these shadow boxes that these are from different people. These are specific memories from life, right? When you can see something and recognize it, that evokes those memories much more easily than what we call recall, which is just kind of cold recall from nowhere. I ask you a question and expect you to pull it out of your brain.
Like a test.
Yeah, like a test, exactly. That kind of memory, you're setting someone up to fail, right? But if you can support them by giving them something to recognize, and then in your interactions also not saying who's that? What's that? What year did you take that picture? That kind of puts you in that testing environment. But if you can turn it into a conversation where I say something, that gives you an opportunity to say something. There's no right or wrong, right? We're having a conversation. Those kinds of strategies we can help with. But yeah, it's something anybody can do, just like kind of making a collection of special items that evoke special memories. Anybody can do that in the home, and it's a really good thing to do.
I was thinking, as you were speaking, there's this movie, and I don't know if you've seen it. It's called A Family That Prays. And Kathy Bates is the lead.
I love her. Yeah, she's great.
She is one of the leads in the movie. So towards the end of the movie, she gets dementia. And so what one of her best friends in the movie is Alfred Whittard. She does exactly what you're talking about. You know, she has like sticky notes and like pictures and, you know, this is your son's name is this, and your name is, you know, really supporting her in this. And what she ended up doing, and it's tragic, Kathy Bates felt like she became too much of a burden. And she decided to take her own life. Do you see that in cases with dementia patients and patients with Alzheimer's, that instead of just being a burden and, you know, my friends and my family are having to support me in this way with the sticky notes and the pictures and the books, I'd rather just not be here?
I haven't personally seen that happen. I have witnessed some of the depression and the feelings of helplessness and feeling like a burden. I did work with one family once that was very, very afraid to broach the subject with their mom because they were afraid that's where she would go. So I think it's a very, very realistic concern. I haven't personally worked with anybody who took that step though. But we do have to consider the psychosocial factors of changing identity and helping someone navigate that. And that's where, you know, I'm part of the team. I support communication and memory related to communication, but it's really important to also include counseling or psychology to support these very big changes in life and identity, because those concerns are very valid.
What are some things that family members, neighbors, going back to your example earlier, can do for a family member or a friend or a neighbor that has dementia? I know you've spoken about kind of doing the book and supporting them with different things like that, but what are some other things that, you know, my mom is suffering with this, my husband is suffering, what are some things that can be done to help?
I think, again, it's going to depend on the person and the family, but there are some kind of basic things. The first one is not disappear, right? Not just decide you don't know what to do, so you kind of walk on eggshells and avoid it, because that leads to that isolation we talked about earlier, right? Just being there, still treating the person with the diagnosis like an adult, right? They don't become a child just because they have a new disease. And if we think about that identity shift we were just talking about, that can exacerbate those negative feelings. So being present, treating them the way you've always treated them, inviting them to do things and expressing like, I'm here to support you, right? Let's come over, I come to you, we go do this outing together, but just being a presence in their life and not acting like this family or this person can't continue to be part of things. Because if you show support and you demonstrate that by being patient, by trying to help communicate, then everyone in that situation is going to realize that they don't just kind of have to give everything up. And you can look for resources in the community, right? When a family is grappling with new changes and doctor's visits and figuring out how to make a book and put these things together, and also the rest of life, which is overwhelming as it is, right? Just everyday normal life. If you have the time on your hands to look up, you know, is there an aging and disability resource center here? What does the local Alzheimer's Association do? Are there any kind of support groups? And not pushing that on them, but say, hey, I found these things, I just wanted you to know, right? The amount of time you could save somebody if you have an extra couple minutes to dig in and find out how to support them, that could save them having to search for those things too.
And you are a professor here at Lamar University in Beaumont, Texas. So tell us about some of the resources that are offered here at the university.
So here in our clinic, we've always offered individualized services where we work with families on determining what are going to be the best support strategies for communication with this person. But this semester we also started offering group services of a very specific kind of service it's a psychosocial intervention for people with mild to moderate dementia. And it's called cognitive stimulation therapy. It doesn't have to be done by an SLP. It was actually designed by a psychologist. But with training in this intervention, it's a series of weekly group meetings with people who have dementia. There's a theme every time, and there are kind of 18 governing principles for the types of things you're doing to stimulate cognition, to promote word finding. It includes memory and reminiscence, and also importantly, it provides access to social infrastructure, right? It brings people together, and I think that is so important, to not feel like you're the only one dealing with this. Be it you're the family member or you're the person living with the dementia, right? It makes you feel like you're part of a community that understands you. Even if you're going through something a little bit differently, you have that journey in common to some degree. So we offer those group services here, in addition to consultations with family members and the person with dementia, so we can kind of figure out what are some other ways we can support communication at home and in the community, so it doesn't just end when they walk out the door.
And if you're needing that information, if you're wanting more support, I'll make sure and have the contact phone number and information so that they can call, and I'll reach out for that. Is dementia a fair disease? Because I feel like, you're healthy, you're fine, you're living your life, you've raised your kids or whatever, you're working, and then all of a sudden, here's dementia.
It's not fair. Of course not. No, and it's typically, in most cases, it's sort of this gradual onset, and might not be uncommon to try and kind of compensate or hide that and be like, nothing's wrong, but then, it's not fair. Nothing like that ever is. No one deserves it.
Is there a test, and I feel like I know this answer, but I'm going to ask it anyway. Is there like a test for dementia? Like there's a test for diabetes and a test for high blood pressure?
Like a blood test or an x-ray or something like that? There's not really, and so for the speech language pathologist, the test that we do, we can diagnose the cognitive communicative disorder, but we don't diagnose a dementia. A medical doctor does that, typically a neurologist, and they can't do an x-ray or run a lab test, but they do a series of behavioral tests where they have the person go through a series of activities and other kind of question answer and observational type tests so that they behaviorally can diagnose the dementia.
I know you were stating here at Lamar University in Beaumont, Texas, that you have like group therapy for the patient and the caregiver. You also have individual therapy for the patient. Is there something for the caregiver? Because I feel like the caregiver takes the brunt of taking care of the patient. So are there groups or books or something for the caregiver?
So here in our department we do communication partner training, but we don't currently have a support group for caregivers. There is in Beaumont, though, there are support groups for caregivers and care partners of people with dementia. And the local Alzheimer's Association website has information on how to access those. I think they happen on Tuesday nights. So I absolutely encourage anyone to find those resources. The Alzheimer's Association, the Aging and Disability Resource Center, one place can't do it alone, right? We need a lot of resources in our community. But we were lucky to get a grant from an on-campus organization called the Center for Resiliency, and they helped fund some of the training and resource development for our clinic. For example, we have these books behind us that they helped fund us getting this collection that people can check out. So we have a number of books that are for the care partner to understand the dementia journey, to provide tips on how to support someone. I just last week had a wife tell me, I set this thing up at home, this memory center, and this book walked me through how to do it, and here's how he's responding to it. And so that's exactly why we have this, so that people can check these out. And it's one thing to be one-on-one and have a conversation, but to be able to kind of sit down and go at your own pace, these are here for that. Another part of our collection is also set to meet kind of through narrative, through storytelling, the needs of younger people. So we have a couple of books for like preteens and teenagers in which, the teenage characters going through their life, but somebody very important to them has dementia, and so they're learning about that and coping with it. And so there's the ups and the downs, so that someone in that age can kind of discover and become educated through the stories. And then we have a nice collection of children's books for much younger kids. So if you have kids or grandkids who you want to talk about this with, and you want to help them understand it through storytelling, through something that's more accessible to a little kid, this can help you have that conversation.
You know what? That is amazing, because even myself doing this interview, I never considered the children. I never thought about the teenagers that have to go through this. So it's great that we have books like these for teenagers, for children, because they get forgotten. I feel like they completely get forgotten in this whole situation. And, one day it's my grandma, and then slowly something is happening to grandma, or something is happening to grandpa, and I just don't know what it is. But no one stops to talk to the kids about it.
Right. And they're so creative. They're all so different, the kids' books, and I haven't picked my favorite yet. I like them all for different reasons. There's one I think it's in my office, I don't have it here, but it looks at memory loss by, the memories are all balloons, and so the little boys, everybody has balloons they carry around, right? And so his grandpa has all these different balloons he shares with him, which are the stories, the memories. They share some of the same balloons. And then he watches those balloons fly away, and one of them is a shared memory of them. So it's not just understanding what's happening to Grandpa, but like that impacts me too as a little kid, right? Because my relationship with Grandpa is changing. So it puts it in language and in concepts that are accessible to a young child and can help them kind of wrap their mind around it. And you're right, they do get forgotten, but it still matters to them. I have so many students I've seen come through, and I ask, why do you care about dementia? And so many of them, it's my grandma had it, my grandpa had it, right? They went through that as a child, and they grappled with learning from it. So kids are so smart and so aware, so they know what's going on.
Right.
And this isn't going to change it, but we're hoping that having access to education and information kind of helps make it understandable and helps kind of normalize that experience. Other little kids go through it too.
What can caregivers do about guilt? Because I feel like they're guilty. They feel guilt because I'm tired of dealing with this. They feel guilty because they snapped. Their patience ran out. They became agitated. Or even they feel guilty because I need a break from this. What can they do about that?
That's so human and normal, and as a daughter who went through illness with my parent, I can relate. And then you have those long-lasting feelings. They aren't just fleeting, right? That guilt stays with you, and I think that's not something within the speech language pathology scope, but making sure you plug into a support group. Not being afraid to find mental health counseling, right? That's a healthy thing to do, to find strategies to cope with the fact that you're a human being. Yes, you're going to snap. Yes, you're going to be frustrated. Yes, there's going to be moments where you just want this to go back to the way it used to be. Everybody feels that way. And so finding access to other people that can help you work through that is very healthy and very important.
How does dementia affect the way a person talks? Or does it affect the way a person talks?
So typically we don't see changes in pronunciation, and early on a lot of the language use is very, very similar. What we do see is over time with the decline in memory, we see decline in word finding, and then kind of using language less and less, so talking less and less, using less complex language, so kind of simplifying, and that the same goes for understanding, right? The more complex something gets, the harder it is to understand and process, because we rely on that kind of working memory to remember what's going on in a conversation, to come back to it and respond to it, right? So memory impacts communication in ways like that as well. And in the later stages, it's not uncommon for someone to really communicate less with language, but that doesn't mean they can't communicate. Observing and seeing, what are some things that they do embodied wise to tell me, do they laugh at things to participate? Do they make a certain facial expression or gesture when they need help? Or sometimes it can be a matter of maybe this person doesn't initiate interaction, but will if someone initiates for them, right? They might sit there because they don't quite know how to start a conversation, but if you come over with, something familiar or kind of start talking, then they have that connection.
And it's the mirror effect again.
Yeah.
Right. So not only are you a professor, speech language pathologist, you work a lot with dementia patients and research, you are also an international speaker. You recently went to New Zealand.
I did.
Very exciting. So tell me a little bit about that trip.
Well, it was beautiful, first of all.
Yes.
I mean, I can't wait to go back because New Zealand is just a fabulous place. It was such an honor and a privilege just to be able to go there and be part of this conference. And it wasn't about dementia work or cognitive communication, but a colleague and I went and we spoke about a collaboration we have between our clinic here at Lamar Speech and Hearing and the local BISD school district, where we work with our students to go into preschool and kindergarten classrooms to support language and literacy development. So the students are all partnered with a teacher, so each one kind of learns to be a collaborator, learns to kind of interact with another discipline, and they find out what's the curriculum, what are the topics, and then they take those and those themes and they create 30-minute whole classroom thematic training that promotes language and literacy development. And so they do large classroom activities, and then they break up into smaller groups so that the speech language pathology graduate students get to manage a whole class, and then they get to manage 4 to 6 students at a time, doing very specific activities that are supposed to be fun. They're supposed to be thematically related to what's going on in the classroom already, so it's familiar, but the kids are learning these really important skills to make them better readers. And so our research looked at the perspectives of the classroom teachers and of our students about that process. What did that collaboration seem like to them? What was that whole experience like? What did the students perceive about learning to be a clinician in this setting? One of my big focus areas is in teaching and learning. How do I become a better clinical teacher? How do we as a discipline learn to understand clinical education through our students' perspectives so we can do a better job of it? So that kind of falls into that, and it's a really fun project and a really great conference to go to.
Good. What is your personal intention as a speech language pathologist working in the field of dementia? What is your intention to do that?
So something that brings all of my tangential actions together is this idea of social access, that people with a communication disorder, be it a developmental disorder, be it a cognitive communicative disorder because of dementia, that all people deserve access to society, to other people, to interaction. And so what I care about most are those psychosocial quality of life aspects, that people need people. Communication requires multiple people. We need to be connected. We need to not be isolated. So in my clinical work, in my teaching, and in my research, I want to look for opportunities to promote that social connection, that social access for people. So what can we do to overcome those barriers to being a participant in life and things that are going on in your community? And there are a lot, there's, around the world, there's some really great things happening. In our country, there's really great things happening. And it's important for me, step by step, finding ways to support what's already happening in our Southeast Texas community and contribute to that.
Do you personally take dementia patients?
So I work with students, so I supervise graduate student clinicians who are providing those services, but I'm part of that. But part of what I do is kind of working with them and stepping back as they become more independent. But yes, I do.
Can you give us some myths surrounding dementia? Some things that we think is true, but it actually is not.
Well, one of those would be the aging thing we talked about already. And I think that that's that ageism, that stigma that old age is dementia, and those are two separate things. Healthy aging does not look like dementia. So that's actually one of the big myths. Another big myth is that someone with dementia is no longer a person. I think sometimes we don't articulate that myth that way, that blatantly, but the way we treat somebody who has dementia signifies we don't see them as a person anymore, and that person is still very much a person, a human with wants and needs and a history, and remembering that significantly changes how we interact with somebody.
As we get ready to end this interview, is there anything else you would like to make sure that we know about dementia?
I would say early identification is really important. One thing I've noticed getting these groups off the ground is that I've talked to family members and people who think they have dementia, but they haven't sought out a diagnosis. Now, there's a number of reasons for that, but I think the earlier you can identify this, so you can start working on strategies. If there's medication that's going to help slow down the progression, the earlier you can get access to that, the better. The earlier you can get in on other services available to you, the better. And I think that there are a number of reasons why people are diagnosed later. One of those is that stigma, right? Kind of keeping an arm's length from something that we're afraid of. But the journey is going to be difficult for families, no matter what. But if you distance yourself from services and support, it's only going to be harder.
And I feel like it's one of those situations, if we don't talk about it, then it's not real.
Yes.
But that is not the case at all.
No.
Well, thank you so much.
Thanks for having me. It's been fun.
Wow, thank you so much for educating us and myself about dementia, and really, I mean, in the midst of this interview, allowed me to realize some of my unconscious biases that I had with for dementia patients. So my very last question for you is, who do you think would make a great guest on the podcast? But you have to help me get them on.
Okay, so I can think of so many people. One person in particular, I work with him in the summers for a community inclusion theater program with kids. Our students here in Speech and Hearing go and help support this. His name is John Manfredi, and he is with Beaumont Community Players. They're a local community theater here in Beaumont. They're about to change their name to Southeast Texas Stages, though, so that's a little confusing because they're going through a name change. He's the executive director, and they do a number of community programs throughout the year, and then specifically children's programs in the summer, and he could really highlight the work that organization's doing in our community, both creatively, and they meet a lot of other needs in the community. And then I have a colleague, her name is Sarah Saldana. She's also a speech language pathologist. But something really cool about her is that she and her husband also run a restaurant, Bruno's, over on Dowling. And, yeah, so I find her really fascinating. How do you do it all?
Yes.
She'd be a cool person to talk to, I think.
Well, thank you so much for sitting down and giving us your time and your treasure with the information with dementia, so I appreciate it.
Thank you.
And thank you so much for tuning in and watching. You can get this podcast and all of my other podcasts on YouTube Podcasts and Apple Podcasts. And always know you have time to listen and learn on the go.
The love, the joy, the ride